Dr. Lee has developed research in pancreatic cancer and genomic cancer, searching novel therapy while leveraging bioinformatic methodologies and basic laboratory testing approaches. The session today is titled Knowing Your Pancreatic Cancer Inside Out. We encourage you to raise any questions. Please use the chat box and Dr. Lee can respond to these after his presentation. So it's a privilege to have you here, Michael. Welcome. I'll hand over to you.
Thank you, Mira, for the introduction, and apologies to everyone. I had internet issues, so had to rush into work and do this from work, and so it's not in the most quiet environment, unfortunately, and so apologies for the background noise if they're coming through. But the way I am as a doctor, I'm very informal, so feel free to interrupt me and ask questions as you go along, because really today's talk is really for the benefit of you that's online. And so very happy to answer any questions, whether during or after the talk. But as a way of sort of introducing myself, I am a medical oncologist working at MacCallum Cancer Center. I have been honored to receive support from PanCare Foundation with regard to components of my research that I'm undertaking as part of my PhD studies at the moment. And this is nearing towards the end of my PhD. And so hopefully some promising data will be coming out. But I will just share with you snippets of it because I think for most of you, really what's going to help you is about what you can do now rather than what's coming in the pipeline. But then I will cover some of the more topical areas and then hopefully give you some flavor about looking after or living with pancreatic cancer. So as a way of a bit of a background, what I'm going to cover on is just a general gist of what you guys all think about is anti-cancer treatment. I think most of the medical team, medical oncologists that's looking after your loved one or yourself, doing a very capable job in that respect. So I will just pretty much brush over it so that we have some context to frame the rest of the talk on. And then what I really want to focus on and my expertise is really in the genetic testing front and how that is relevant to looking after someone with pancreatic cancer. And then looking about clinical trials from the perspective of us as doctors, what do we consider when we open clinical trials? And really to share that perspective with you to show that why it can be difficult and what you can do to navigate that space. Translational research is where I touch on a little bit about my research and how PanCare has helped along this way, and more of the topical stuff such as the mRNA vaccine in the COVID days and medicinal cannabis, as lots of you are confronted with that. So I will touch on that and finish with what can you do for yourself, which is the most important aspect about living with pancreatic cancer. So really, pancreatic cancer, we talk about it in scientific terms as pancreatic ductal adenocarcinoma or PDAC. These terms you'll be used interchangeably. It is a disease that is increasing incidence over time since 1982. You can see the steady increase in the blue line, but this is to do with aging population. But even if you adjust for that, there still seems to be an increase in incidence, which we as medical professionals don't really understand. But what that translates to is in Australian statistics that in 2022, which is last year, it affects about 4,500 of us every year. In another way, it means the new pancreatic cancer is diagnosed just under 2 hours, once every 2 hours. And what's sad about the statistic is that out of the 100 of you within a year, the survival is not great in terms of statistics, despite all the advancements. And in the 5 years' time, there might be only a 12% survival rate, which is really poor compared to all the other cancer type that we treat in medical oncology. As a way about pancreatic cancer, if I may, I just want to start off with a bit of a basic anatomy. So you have your food pipe, your esophagus that you swallow, goes into your stomach. It enters into the first part of the small bowel that we call the duodenum, where the pancreas sits is actually behind the stomach, as shown in this diagram. And then your bile duct from the left side and the right side of your liver actually drains into the pancreatic duct. So where this diagram fails us is actually the bile duct actually joins onto the pancreatic duct and then forms a common duct. And then before it release all the digestive juice in terms of bile, pancreas is important in terms of secreting pancreatic enzymes for digestion of all our proteins. So you can imagine if you have a cancer growing at the head of the pancreas, you can get a blockage of these ducts. And this is why people can present with jaundice, which is meaning yellowing of their skin. And that's a phenomenon that happens when your bile can't empty into your bowel. It spills over back into your bloodstream. And that's the bile is what makes your skin yellow in that context. At the same time, any blockages along this way, you inhibit your own secretion of pancreatic juice, in which case you will find it more difficult to digest fatty foods in particular, and some of the proteins, which relies on the enzymes from the pancreas. The purpose of sharing this complicated diagram with you is to also show you that the pancreas, although behind the stomach, it actually just sits in front of these major blood vessels. And because of that close proximity to the blood vessel, you can imagine if a cancer grows around here, it doesn't take much for it to start wrapping around these blood vessels. And this is important because whether the surgeon can take your pancreatic cancer out up front, it depends on whether it's all about its relationship to the blood vessel. If it's wrapping around the blood vessel, then the surgeon can't take this out successfully. Then what I have for this is for the minority of you who are lucky enough to discover pancreatic cancer early in the piece, you may be faced with something called a Whipple surgery if you had a head of the pancreas, pancreatic cancer, is they literally chop out the stomach where it goes into the first part of the small bowel. They also chop out the pancreas where the head is. So you literally split the pancreas in half down here. And what they do then, they chop off the small bowel here. They bring this loop all the way up. And so you end up with a blind loop here. And you join the tail end of your pancreas to this blind loop, and you join your biles into this groove. And then so all your secreted juice sort of comes down this way. As you swallow your food, it empties into your gut directly. And this is why Whipple surgery can be horrible to recover from, because normally what we have a much bigger stomach, and we will expand as we eat food, and it's like a rubber band. And so that will allow us to sort of digest our food and in a controlled way, empty into the bowel. But now we just lost the function of that emptying function. We just, whatever we eat, we try to jam it into a small pipe. And that's like all the hair follicles down your drains, and that gets it clogged up very easily. And you can imagine that's why people after Whipple surgery feel full very quickly. It's because of the plumbing has been changed in that way. And so unlike other cancer type where they talk about stages of cancer, in pancreas role, it really is separated whether we can cut it out, what we call resectable, or whether we have some degree of difficulty where we call borderline or locally advanced. That really, the terminology between the two really depends on how extensive that cancer wraps around the blood vessel that we're thinking about. Or in the last area, we think of metastatic, where we're saying it's really in the sense of it's spread to another organ. So if we focus on the first group, where you are in the 10 to 15% of you are able to go for surgery directly, you go for this big operation that you have, and then within about 8 weeks, you typically recover sufficiently to the point that you feel you can eat probably about 50% of what you normally could eat before the operation. Then we are talking to you about giving you chemotherapy to wipe out any small cancer cells that the surgeon couldn't see and have not taken out, or that has been spread beyond the surgical fields. And even with that, the survival, in 5 years' time, a lot of you may have succumbed to the disease, or more than half of you may have succumbed to the pancreatic cancer, even in that setting. And that's a more really terrible statistics that comes with pancreatic cancer. And then in the second group, is where we think there's difficulty where the surgeon doesn't think that they could get the cancer out directly. They then send you to us as a medical oncologist to have some chemotherapy upfront in the hope that we can shrink the cancer and therefore we'll be able to go for surgery. Now, you might hear the term borderline resectable, and the doctors talks quite positively. We're saying we're still going for a strategy of cure, but knowing that only about a quarter of you actually make it onto surgical resection there afterwards. And conversely, we could be quite pessimistic and say, look, your cancer is really advanced. It's not looking good. We're unlikely to be able to take it out in what we call a palliative approach, meaning that whatever treatment we give you is only going to control the cancer. It's certainly not going to get rid of the cancer. But amongst that, despite our pessimism, there's about 10% of you will get to surgery and potentially still go on to have a cure. We then, once we sort of set on this course of chemotherapy, we typically require you to have 2 to 3 months of chemotherapy, and then we do another CT scan. That's what I mean by reassessment. Then depending on the response, some people may say, look, let's have more chemotherapy. We may think about adding in radiation, or it's such a good response, we can plan for surgery. And we would do this until sort of up to 6 months of chemotherapy. And if you're still not to be able to go to surgery because the cancer is still wrapping around the blood vessels, we would say this is unresectable, in which case we're really in a kettle of fish of palliation, meaning we're controlling the cancer. But we still get a reasonable time frame after that, obviously not as much as we like. I think I put up this slide is really, this is a slide where a surgeon has gone on to 6 different cases. They've taken them all the way through chemotherapy and then taken them to surgery. And then they got a good result suggesting that they got all the cancer on the final specimen. Then putting in all the clinical details across the 6 different cases, they then put it to about 150 surgeons, and majority of them are sort of academic, really highly experienced surgeons here. And you can see in the blue and the red, there's what that represents is the blue are the one looking at the same case and looking at the same images, which is all the information that we have. There's quite variation in terms of whether they decide to offer this patient, the same patient that got a good outcome from the surgeon, the result, whether they will offer surgery. And what I'm trying to say here is that often these are tough decisions. One surgeon may tell you this is you would be able to go for surgery. Another surgeon might say so otherwise. But it's really hard to know, because if we gone in and had surgery and it wasn't good outcome because we didn't get all the cancer out, then you would have ended up with a massive surgery with no real benefit. But then at the flip side, out of these 6 cases, the people in the red would have potentially missed out on a curative resection, potentially, by seeing different surgeons. So it is very difficult, and this is why we all work in a multidisciplinary team, and therefore we sit down together as specialists and to try and minimize this variation as much as we can. So for those people who unable to go to surgery with the addition of chemotherapy, or one thing you guys may read about is something that's called nanoknife. Now that sounds like a fancy term, and what it is they actually put electrodes through the tummy. They can either do this through the tummy, or more commonly they would still open up and put it directly into the tumor. And what they do is they plant these electrodes along the blood vessel and along the pancreas. And what the idea is that you zap electric currents between the electrodes and then to zap the cancer this way. And the benefit of this is because this is electrical current, it's going to kill off the cancer cells and not damage so much of your blood vessels. This is a very specialized procedure. It's pioneered out of Louisville in Texas. And what I have shown here down the bottom is this is across time. Each dot is a study that's showing benefit or not. So what you want to see, this is what you achieve. This very faint dotted white line is what you achieve with chemotherapy alone. And you can see all the dots down below would suggest they actually done harm because they didn't result in a good outcome. But it's over time, you're starting to see people getting good at these procedures, and you're getting really good outcome and better outcomes than chemotherapy. And so in very selected centers, there potentially is some benefit of this approach. Now, in terms of local expertise, especially where I'm sitting in Victoria, there is a trial at one of the private hospitals looking into that. And that may be a consideration for some of you that you may want to discuss with your team about. But I feel overall, it's not a strong evidence for it to be better. And it's not an easy walk in this park, in the sense that some of them do experience severe side effect. Anything, depending on the study you look at, it could be as much as 40% have a severe complication following the procedure. Then lastly, we talk about once the cancer has spread to other organs, then we're really giving chemotherapy with the intent of controlling disease. And what that means is, overall, the statistics tells us, unfortunately, 50% of you may pass away with pancreatic cancer on average. That means 50% of you will do better, or 50% might do worse. And really, that's the best chemotherapy, assuming you're the fittest and you're able to tolerate all the chemotherapy and treatment. That's what we can achieve. So really, there's a strong need for new therapy option to hopefully improve these statistics. Now, what you might hear is melanoma used to be the same type of statistics as ours, and if not actually worse. But with the discovery of immunotherapy, it has really revolutionized melanoma in that 50% are alive at 5 years, whereas in pancreatic cancer, we haven't found that breakthrough. And so it remains in the clinical trials and to look at our other treatment options. So there are two common regimen that's funded in Australia in terms of chemotherapy. I'll take you through this. So this is what we call a Kaplan-Meier curve. What that does is we follow people along and help wherever there's a cross on the curve. What that tells us is they only just recruited a patient in the trial and they followed them up for a couple of months. That's where the data stops. And then they follow every time someone dies on the trial, you take a dip down, and then gradually you do this ladder approach, and then you work out how many people have died and what is sort of the average survival. And this is how a doctor works out what your average survival is. And that's why you can see our estimate of your average survival is poor, because there's a whole bunch of people that's still alive. What's to say these people up here that's been what we call censored, because we don't have any further data, because they haven't been in the trial for that long for us to know what their outcome is, they could be doing better. But I think the key point I want you to take away from this complicated graph is to say whether you get one chemotherapy to another really comes down to how your oncologist thinks how fit you are. Typically, we use a FOLFIRINOX regimen for someone who's much fitter. And for someone who we might want to have a bit more shrinkage up front. But in essence, when you're in the metastatic stage, it differs not really by real world data, and this is Australian data that we have showing here, that it makes no difference which chemotherapy you're on, and really it comes down to which one do we think you're better able to tolerate. So we sort of talk about sort of anti-cancer treatment, and that's sort of the general landscape where we think about whether we can go for surgery upfront, or do we go for chemotherapy and then potentially surgery, or in the third group, we just go for chemotherapy to control the disease. That's sort of the sort of the treatment landscape. And what I want to talk to you about, and which not perhaps your oncologists don't spend as much time on, is the genetic testing and how that is relevant to your pancreatic cancer. And that has some implication for you yourself living with the cancer, or it also has implication for the family. And then people talk about molecular testing of the cancer, or the correct terminology is called somatic testing, which means you're testing the cancer as opposed to germline testing, which is testing for genes that you could pass on to your children, where that differs to somatic testing is just a defect within the cancer and you have no way of passing this on. And this is just something that your cancer has acquired over time. So this is a study I was involved with when I was in Canada. And so we recruited a patient between 2015 and 2019. And sort of over that 2.5 year period, we looked after about 300 patients. And we had what we sort of, the salmon pink circle on the right is that we found, genetic defect in patients with pancreatic cancer that could be passed on to their family. And at the time, and prior to the guideline changes, there were set criteria that you would test people for. And this is what's represented by people in the blue. So you would test 70 extra people based on a guideline, thinking they may be finding some kind of genetic defect that they could be passing on to their children. In actual fact, by doing so, you only find 11 people that you're really interested in, but then you miss half of them, or more than half of them, of the other 13 if you apply this criteria. And this goes back to the point is family history we typically think of is important to predict whether if you have something wrong with your gene, if you had a whole family history of cancer that's related, then could that be driving the reason why you got cancer in the first place? And reality is we can't rely on family history to predict who is going to have these changes. And so the international guideline is that we should be testing everyone with pancreatic cancer for genetic defects that could be passed on to their children. In reality, we're only going to find 5 to 10% of you, depending on the study we look at, in terms of something wrong with your gene to pass on. So if you don't do this, chances are 90% of you will be fine. But what's important is if you're in that 5 to 10%, you have a significant loss of first-degree relative or second-degree relative where your results may affect what they do about their risk for other type of cancers, such as breast cancer, ovarian cancer, prostate cancer, then it has huge implications for that. And one of the difficulty in accessing all of this tests is, one is about the cost of it, and two is often the oncologist sends you to the genetic counselors, but there's a huge wait list for the genetic counselors, and it ends up being a long time away. And so there's a move in the field where the oncologist is trying to gain your consent and talk to you about what the implication of genetic testing is, and then get you to sign on and do the testing and only refer to the genetic counselor if there were something significant, which is fine because reality is 90% of you won't have anything, but it's good to cross the T, dot the I. What does that mean for you practically? The test could either be a blood test or even more simple, it could be a swab inside your cheek and just grabbing some of the cells inside your mouth. Depending on where you are, it could be free. Sitting at Peter Mac, what we do is anyone less than 60, we'll fund it for free, but anyone older than 60, unfortunately, they have to pay. And depending where you order your tests, it could range from anything between $450 to about just under $600. But what it does require is an oncologist or genetic counselor to go through what the implication is of doing a test like this, because it has potential implication. If we find something, it may have implication for your treatment. What people worry about is it has implication for their insurance. The main thing is to say, like most insurance with pre-existing conditions, if you already got insurance, it shouldn't affect you regardless of your finding, but it may affect the first degree relatives, so such as your siblings, getting future insurance because they will have to disclose that there may be a genetic mutation that predispose them to other type of cancers. But I think more importantly, from my perspective, is that it has implication for your family, because if we did find something, genetic mutations, there may be something they can do about to screen for certain cancer earlier and then doing something about that. And I think the most widely known gene in sort of genetic defect is probably the likes of BRCA, like Angela Jolie, who is a movie star, and she had both of her breasts off because of herself having the BRCA gene increases the risk of breast cancer. And certainly, I'm not sure what she's done with her ovaries. There is also increased risk of ovarian cancer if you have the BRCA gene as well. So there's a whole host of things that you can do. But what we do these days is we don't just look for genes that's relevant to pancreatic cancer. We have the option of doing a panel testing, in which case we might find genetic defects that may have nothing to do with you developing pancreatic cancer, but does carry some risk where your other family members might be more likely to develop other cancers. And I guess from a doctor perspective, knowing more is always more powerful, but that's my perspective. But certainly some proportion of my patients would feel like they rather not know, and because it's not something they could do anything about other than and that is true for some of the genetic defects, so they rather know, and that's some of the reason they don't go ahead with genetic testing. Once you decide to go for genetic testing, it could range anything between 3 to 12 weeks, depending where you order your tests. Then if it's positive, then you obviously have time spent to see the genetic counselor, and that can be a worrying time because once you get a test result, there can be a bit of wait to see them. And then for your families, once you have found to have a variant, then we can screen for your family whether they have the specific genetic mutation that you carry as well. But the key thing is, unless we find a genetic mutation in you, we wouldn't be testing for the rest of the family. So say if your daughters or son want to be genetically tested, we wouldn't be offering them the test without necessarily finding something in you first. So we talked about sort of BRCA genes already up until this point, and this is relevant for pancreatic cancer because it does increase the risk of pancreatic cancer. And if we look for all the things, all the patient, about 4 to 7 of you potentially out of 100 could carry this gene, and that contributed to your pancreatic cancer. It does have some implication for your treatment. What that means is I could potentially swap it for a tablet. And the benefit of that tablet is that your disease might come back 3 months later. The downside is, even if I gave you this 3 tablet, and so you're happy because you're not having chemotherapy per se, then you don't feel better for the 3 months you don't have the disease come back. Compared to the Joe who didn't go for this treatment and they just stayed on chemotherapy, you don't live any longer. And what's more, kick in the gut is because of the funding, it's currently not funded as a treatment in Australia. You would mean that you have to pay about $56,000 more compared to if you had chemotherapy. And one of the type of these tablets called olaparib. And really it begs the question, if it's presented in this way, would you really want it? And I guess the way I'm presenting it, personally, I'm counseling my patients not to go for this option, even if they have this particular mutation, because I think we could achieve the same outcome with chemotherapy and I'd much rather my patients spend $56,000 for other things if they have the spare cash to do so. And really, we want to be looking for targeted therapy or non-chemotherapy options that may offer us with more treatment options. But in pancreatic cancer, it's really looking like a needle in a haystack. The way I think about things for pancreatic cancer is that we should do germline screening for everyone in terms of genes, and that will find 5 to 10% of you that may have some implication, really for your family, not for you per se. But if we did this, what I call somatic testing, or what genetic defects specifically wrong with your cancer, but it's not something you pass on to anyone else. If I did that for all the patients I see, I really only help about 2.5% of these patients. And that's really because there are a whole bunch of other rare variants that we can find, but they're very, very uncommon. And the way I think about things before recent changes is I look for a specific gene mutation called KRAS. So it's a gene that can go wrong, and it does go wrong, and drives pancreatic cancer development in about 90% of you who have pancreatic cancer. And if you have that gene, chances of me finding a rare variant where I have a drug for is going to be less than 1%. Then I say, look, chances is very low. I will probably forget about doing further testing, because really, if I need further testing, up until recently, it will be something in the order of $2,500. Now, you may be one person that say, I don't want to leave any stone unturned, so you will pay that $2,500 for that potential less than 1% chance. And really, I say to people who are not in the financial ability to pay for that, I don't think you're going to miss out much, because even if we find something of actionable, because you have this genetic defect, whatever therapy I give you that's targeted in that way may not work as well, or may not work as long, because this is almost like a bypass mechanism that makes the cancer grow worse. Whereas on the contrast, if you don't have that mutation, then which applies to about 10% of you, your chance of finding something that you could target is in the order of 20 to 25%. Then I think it's much more worthwhile. And prior to recent changes, this would mean that we could access these testing for free under what we do for research at Peter Mac. But what's more exciting, so before I get onto that, if I remind you the curve when I said to you, in advanced pancreatic cancer, which chemotherapy doesn't matter, but reality is from genetic testing, we could identify a subgroup of you where it does matter, where if you see the curve on the right, is that if I give you the platinum chemotherapy, which comes in the FOLFIRINOX, there's a platinum chemotherapy in here, and there's no platinum therapy in the gem-nab-paclitaxel arm, you actually do better. So there is some merit to genetically testing your cancer. But up until recently, it's been very difficult, because to find this out, I really need to spend a lot of money to do that. But what's exciting is right now, literally opened literally almost 2 weeks ago, there's a private and public partnership that you may have heard about. It's called Omnico. And Roche is one of the drug company that's been funding a significant portion of this. What they're offering is for 50,000 Australian person with cancer, they could get these genetic testing that I said was $2,500 for free, as long as you have what the doctors feel like it's incurable pancreatic cancer, or any cancer for that matter. They would then test your cancer. They put us through a molecular tumor board where all the specialists discuss what we find and what that means. And the downside for you, the onerous part for you, is there will be a bit of questionnaire to see how long you live with whatever treatment we give you. And then we take whatever biopsy left over of your biopsy that you don't need, and we bank it so that researcher like me could access it and do the studies that we need to do to find novel therapy. And all it requires is talking to your oncologist and referring you through our online portal. The study is based in New South Wales. They will consent you, they'll do a video conference with you and get a consent, arrange for all the biopsy to be done and tested. And your oncologist will get a report about what are the actual mutation and what we recommend based on whatever we find in about 8 to 10 weeks time, and it costs nothing for you. So I would say this is one thing, if you take away from today, is go back and talk to your oncologist about doing this testing, because right now you have the opportunity to do this for free. And I've talked about this less than 1% if you're in this group and it's not worthwhile, but right now someone's footing the bill, and it will be in your interest. What happens if you're in that less than 1%? Then you could access that potentially and have additional options that's not chemotherapy. And so that's a worthwhile consideration. This takes me on to the next part of the talk, is talking about clinical trials and sharing a bit with you about our research. This is another good website that I do recommend. I am based in Victoria, so apologies for the others out of Victoria state people, because I don't know what's equivalent in your state, but you can use the same thing. It's trialscancervic.org.au, and you can search for pancreatic cancer. And look, it's exciting. It looks like you have 122 trials open that you could participate in or benefit from. But reality is that's far from the truth, because a lot of these trials is what we call early phases, where it's really about safety of the drug, and they would recruit any type of cancer where they have no treatment options. And so it's very hard for you to then go decide, of the 122, which one do I go for? And that's a hard number for us to think about from a doctor perspective as well. So sitting from my position is that we are now looking for these biomarkers or these genetic defects that makes it very difficult to find, because at low percentages, you have to screen lots of people to find them. But we are doing them. But it does mean our patient is spread throughout. So sitting at Peter Mac, my catchment area is essentially within metropolitan Melbourne, but I have patients all the way out as far as, Maduras and things like that as well. But obviously the geographic challenge does pose some challenge in terms of participation of trials, but we're changing that slowly. But the practical sense is, because of these rare mutations, out of that 122, a lot of you will think that that's a lot of trials, but when you boil it down to the actual number, when you're looking for these rare variants, it weeds out a lot of the trials very quickly. To an organization such as Peter Mac, there's an exciting trials called Aspire. Now, I say that this is exciting because this trial, they have done the initial trial and shown 14 out of 29 had tumor shrinkage with treatment of this additional thing. And 10 of them, another 10 of you out of the 29, so 24 out of 29 really benefit from this additional treatment, because their disease remained stable and didn't grow. And to us, that's a win. As long as the cancer doesn't grow, that's always a win. And you would say, look, 24 out of 29, that's really good odds. And that's true. But when the study came across to our table, we didn't go for it. And the reason behind that was it's a small biotech company, and they only have one of this drug. And when they only have this drug, and if it fails, and reality is majority, 90% of the compounds, when you go into the next phase, when you recruit more patients, the numbers don't look 24 out of 29. They probably look at much worse than that, and they don't go on any further. And so we would have, as an institution, we would have wasted all our resources going for this that goes nowhere. Whereas in some ways, we tend to go for a bigger pharma company trials, because we establish a long-term relationship. So when the big pharmas come out with the newest compound, because we have good relationship and working understanding, we might be the way to access to those more promising compounds and be able to give it to our patients much faster. So it's a contention about resources of what we can do. But this trial is open in Austin, just a couple of kilometers down from us. But not saying Austin is a smaller academic site by any stretch of imagination, but sometimes certain trials are able to open at these different sites, because they have we all have certain capacity to do these smaller trials, but we just can't do it every single of these smaller trials. At the same time, because there are so many research sites around town, that we have a lot of competing recruitment. So some trials might be open at Austin, and we will choose not to open here at Peter Mac, because the proximity, we don't want to be competing for the same patients. At the same time, when we think about treatment, it's really hard. What I don't share with you is, say, if you got through first-line chemotherapy and your cancer's growing through that, by that time, only about less than half of you, something in the order to 40%, make it onto second line, because that means 60% of you either feel too unwell to go on to have more treatment, or a lot of you is because you saw that how it felt on chemotherapy and didn't make you feel that much better. And so you're saying, well, if you're not promising better results than the first one, then what's the point? And so if you imagine, if I gave you all the treatment options, which is, the standard would be 2 lines of chemotherapy, then and you lose sort of 60% of you each way, you get to the last line, it becomes a very small number, and therefore it makes it really difficult to recruit. And so therefore, us doctors is trying to move some of the untested therapy into earlier lines, say after the first line chemotherapy, then we might introduce another treatment or repurposing a drug, in this case, sulfasalazine in the SPEAR trial. Then what we do is we'll say, look, this is an unproven treatment. It may have some benefit, but the downside, the cost to you is you may be forsaking another chemotherapy that may have some proven benefit. But again, I can't tell from the get-go who's going to benefit from that chemotherapy. And that's an uncertainty part. And therefore, some doctors are not comfortable with that concept, and therefore wouldn't necessarily ask their patient to try for that. But that again comes back to the patient themselves, in the sense how well they are, whether they are unwell. But I think the biggest limitation is, and admittingly so, that I'm not aware of every single clinical trials that is in existence, even within my own state. And that makes it really difficult for the patients I look after, because they will be looking to me saying, is there clinical trials? I can say yes or no based on what I have, but there's no guarantee I know every single trial that's open at the other hospital, because they come and go and they change, and takes a long time. That I might maybe thinking certain hospital down the road has this other trial, but they actually haven't got around to opening the trial, because there's a lot of process it takes to open a clinical trials. So, and as doctors, we also like to support the works that's developed our own. So things like Ascend, which is chemotherapy plus the SEN1 compound, actually developed out of Australia, and they're showing promising results. But supporting these trials, which is typically less well-funded in pharma, then I have a bit more overhead on my side. And so financially, I may not be in a position to do so many of these trials as well. And this is why there's a discrepancy in terms of how many trials open versus not. So what I've just gone through, you're like, great, this is what you doctors think about. But what does that mean for you is that the first thing is trials have a very niche target population if we're selecting for a specific genetic defect or biomarker. And so a lot of that 122, when you look at it, may not be relevant. The clinical trials, because sometimes we ask you to forsake, a proven second-line treatment, you really got to ask the doctors, what's the science behind the trial, and how much do you believe that science actually works? Because sometimes we do trials where we think this is a good idea based on what we can see in animals and cells, but when we turn it into humans, then it's a very different story. So one thing is you throw the baby out with the bathwater by, going after something like a clinical trial. But at the same time, on the flip side, all these miracle drugs that's changed life, they all start with the early phase trial where they don't have much evidence, and you kind of have to have a skin in the game to win it. And so this goes back to my point, is to say, if you're had a standard chemotherapy and you're one of those that were lucky, you really don't have much in ways of symptoms, you're not feeling unwell with your cancer, then it may be something that you would consider. But with any clinical trials, there's always time and energy, because we'll ask you more questions, we'll do more blood tests. And is that really best of how you use your time with your loved ones going for this miracle cure? Because we forget there's a lot of costs going for these treatments, extra appointments and whatnot. But sometimes if you take a step back and say, look, having to think about all those additional appointments and time, it may be better spent spend with your family. And that's a hard decision to come to. And this is where your oncologist would be there to sort of guide you through that process. But I think the most important thing is your oncologist simply may not be aware of all the clinical trials. So have a search, by all means, have a look through those things and ask your doctors to say, look, hey, you know, say you live closer to the Monash area. For those of you who's not in Melbourne, they're sort of in the southeastern corridor as opposed to in the center of the city. Then you might say, hey, that's closer to me, and that might be they have these trials. Are these one I should be considering? And your doctor could quickly look through that and quickly be able to tell you. So I would say sometimes don't just rely on your oncologist. You could ask them yourself. Furthermore, if you're really into doing something as a carer, as a patient, you could become what we call consumer advisors and be a patient advocate and help us design the trials that is relevant. You could help us fundraise for some of these initial trials. But I think the flip side, and we don't see that as much in the Australian setting, because the philanthropy, as much as we want it to be a massive component of our care, but it's not as big as what the US movement have been. But what they're faced with is family may be backing certain drugs for rare diseases, and then join forces with some commercial company to take it to trial. And then at a later stage, it's not going as well as the company had signed up or hoped it to be, but for financial reasons, or they simply don't have to disclose, they said, look, we're going to stop investigating this trial. And that's putting a huge backlash from the community, because they've been invested in so much, and suddenly they hit with a roadblock that they can't overcome unless they give the company more money, and by which time you feel like you're being sort of taken advantage of. Which in some way, to be fair, yes, that's true. And in another way is, this is the unfriendly nature of today's world, is that a lot of these drug development does take time and does take a lot of costs. And so financial decision does come to it. And even for us as clinicians working in a public health system, we try to do our best, but we still have to consider which one we do. So now I digress a little bit, if you indulge me. This is the type of research I'm doing. The way I talk about multi-omics, it's just big fancy words of looking at things from a different angle and putting all the pictures together and finding the answer. And my description is, it's like finding MH370. Now, you know, if I take one step back, is to say, what you and I are more familiar with science experiment is we do one thing, say we put ice in the heat and we see how quickly it melts. We repeat the same experiment in the cold situation when repeated over multiple conditions, and then eventually find the answer. But that's sort of the traditional way of doing things, but the disadvantage of the strategy, it takes a long time. So the first targeted treatment for cancer you guys would have heard about is Herceptin. Well, it's probably it really should be imatinib in the hematology space, where this wonder drugs has changed the world of difference for people with hematological malignancy. But that took 50 years between discovering the target and actually coming up with the path. So how we think about things these days is we try to map situations, mapping from all directions. So it's like finding MH370, we could use the satellite data to figure out where potentially the plane could head. We'd use the data from where we find debris of the plane and to find out the answer. And really it's about integration of all these data, and hopefully we find it. But hopefully my research is not like MH370, we will find a target and not left in the lurch. But I use, you know, coming back to my Kiwi origin and using sheep as an example, if you use the image on the right, you see this herding sheep opening the floodgate, and they all sort of move in the same direction. And what this analogy I'm drawing on is, if you imagine every sheep is a gene in your body, of which there's about 19,000 genes in your body, and I hit it with a drug, that's almost like opening the gate. Then we can see what happened to the genes and where are they going. And we really can follow these paths, then tells us about how a drug is working. Now you can see some sheep here have gone on into their own spinning. And if I try to find here what's happening here, I wouldn't get the right understanding as if I was following the rest of the sheep going that way. But because there are much more sheep going this way, hopefully it drowns out the noise that's occurring here. And then eventually I'll get to the right answer. That is as opposed to here, I let one sheep through, see what happens to him or her, and then let another sheep through. And imagine I have to do thousands of times, and each time it's the same time to do one experiment, then it takes a long time for this target to develop. So that's the analogy. What does that actually mean in real life? What I do is I hit my pancreatic cancer cells that I have grown in the plasticware, in the petri dishes, and then I hit them with a drug. Then I look at what genes are being affected. So they put the genes into different clusters or different pathways. And then I can see, oh, compared to each different colors represents a different pancreatic cancer cell line. They are all behaving very differently in response to this gene. So it's not giving me the consistent picture I want, but we can then look at the effect of time. They're all showing a consistent pattern where certain genes are turned off in the first instance, and then really turned on by day 6, where I see the activity of the drug. And that can tell me something about the biology. And this is something we call RNA-seq, and looking what that is just looking at a whole gene expression and how, once you hit it with a drug, how does that affect you? Then we can ask the question, okay, so we know what the effect of the drug is. Well, who's the important player? So, and again, goes back to, we can do a whole screen where we knock out a single gene within each cell, only one gene, and then we culture 19,000 different genes, if you like, with that's knocked out in these cells. And then we apply the pressure of the drug. And then what we look for is cells, the clones that disappear first, that will tell me maybe they're working with my drug to make it more effective. And that will tell me something about how the drug works. And then at the end of the experiment, we look at which clones are growing more, because we might have knocked out an important gene that is required for the drug to work. So if this gene is not working, then my drug doesn't work. And therefore, these cells are able to proliferate much faster than other cells which have genes knocked out, but are still under the pressure of the drug. So it's like, the weeds that's grown resistant to the weed killer that you grow, and which are the more resistant weeds. And that's what we look for. And that can tell us about what functionally, how that drug works. So this is me looking at drugs that work together. So PRMT5 is the target I'm looking at. So PRMT1 is another target that could work well with it. Then I say, okay, so these are the important genes, but how are they interacting with each other? And then I can then say, well, if they are important, working with each other, then is there a low expression of this gene suggesting the drug is inhibiting it? And it's just basically, simply put, intersecting different data pieces then tells me, out of all these important genes, this particular gene may be the most important target of understanding how it works. And that takes a 19,000 gene down to one target or couple of targets for me to focus on. And then that's how we can now work out how this particular drug works. Another avenue I'm taking is sort of, if you think about, these are birds in the Hawaiian archipelagos, the honey creepers. But because of different habitat, they end up over time producing different types of beaks to cater for the different type of flowers that they find in the different regions of the archipelago in Hawaii. And so if I can simplify this, is that they may change. They all have the genetic code to make a beak, but they make different versions of this beak to cater for what they need. And so in cancer, they can make different versions of the proteins, and it may work better in certain ways. And so when I hit it with my drug, a PRMT5 inhibitor, remember I said PRMT1 is helpful. This diagram is showing is they hit different amount of target, but when combined together, they commonly hit 219 targets. And my challenge is it because they're both hitting those 219 targets better and stronger, and therefore making the combination more effective killing pancreatic cancer? Or is this the novel 2,400 events that makes it I'm hitting a new target, therefore the combination is better than if I use either agents alone? And really, that's a challenge that I'm dealing with. We're really dealing with big numbers. We're not dealing with one at a time. And sometimes it leads to a lot of confusion. So, the birds develop adaptation to suit their environment. And I draw the analogy that in the UK, the Scots and the Brits, the Scots took on skirts and the Brits took on top hats. I'm not sure what the advantage is. And really, that's a bit of research. Sometimes you're as confused as that. But fortunately, if I make you even more confused, is that pancreatic cancer, there's a gene defect in P53, which happens in about 60 to 80% of pancreatic cancer. Again, what it does, it increases the expression of this gene. And what this gene does is makes different versions of this GAP17 molecule. Normally, GAP17 stops this KRAS gene that we talked about that drives a lot of cancer driving growth in pancreatic cancer, and it stops its signaling. Whereas when you have increase of this HNR and PK gene, the type of version of this GAP17 it makes is that it doesn't associate it with the KRAS gene, and it stops it. In effect, it keeps on signaling through the KRAS and arrives continuous growth or stimulation signal for the cancer cell to grow and making a more aggressive cancer. And so through all that sort of analogy of intersection and putting everything together, I'm starting to think my drug is hitting this particular protein, and that may be the way it's working. But that is yet to be proven, and we just have to do the validation experiments to prove that. And that's the last bit of my PhD to do. But all of this, up until this point, putting all that together has already been almost 3 years. So research, unfortunately, doesn't happen at a fast rate. And what you guys may see is the hype right now in the media is this mRNA vaccine. We saw how mRNA vaccine was very successful for COVID. Now they turn this into a cancer therapy. And so what they do is they cut out your cancer. They look at the genetic makeup of the cancer. They pick out specific areas on your cancer that we could generate a vaccine for. And then we prime your immune system by giving you immunotherapies to stimulate your immune to work better, and then give you doses of this vaccine that we talk about. And then we come in with what we say standard chemotherapy. By that time, you're 21 weeks or really 5.5 months down from you finishing surgery. And really, we lost more than half of you who's developed other diseases or have gone off and do other things because you're fed up with the waiting time. But of the people that do go on, half of you respond to this vaccine, and half that response, we think only half of them have a credible response, what we call a polytope, meaning you're generating a response to different pieces of the cancer. And really, if you do the math, then that's 4 out of 32 that benefits. You would say that doesn't look very promising, but there's a lot of excitement in the pancreatic cancer world because that's a proof of concept. Sure, there might be a lot of work to make this therapy better and benefit more people, but at least this could be something that's worthwhile. And what's exciting for melanoma, who's much more ahead than pancreatic cancer, I talked about pembrolizumab, which is one of the immunotherapy. It really revolutionized the treatment from me saying the survival is worse than pancreatic cancer to 50% are alive at 5 years. Now, adding in this vaccine, it makes that even better by 44%. Now, that's not a 44% better overall in absolute numbers. It's 44% relative terms, meaning in absolute terms, it might be only a fraction better, but it is at least better. But it does come at a cost of about 14% do have serious side effect. Surprisingly, the placebo arm also had 10% has serious side effects. So maybe we're harming 5% of you more, and that's it. But at the same time, it is an excitement. But you can see this is an excitement rather than reality of what you can do at the moment. So last bit, medicinal cannabis is a very difficult topic for us doctors to talk about, because really there isn't good evidence that it works. I think that's the foremost important thing to say. Out there in the market, there's what I personally would say is that oil formulation is more reliable, because as opposed to inhaling it, eating it is the worst, because eating it, the absorption of your cookies, your edible marijuana is a bit more variable, especially for people with cancer of the GI tract or pancreatic cancer, bowel cancer. The absorption is a bit more impaired because you're not eating as regularly and whatnot. And so there's less predictable when you're going to get a benefit from that marijuana treatment versus not. And really in marijuana, there's two components. There's the CBD component, and the THC component is a component that makes you high and stoned. But that's also a component that drives a good appetite, which in a Western medicine perspective, I don't really have a good medication other than steroids, which comes with a lot of side effects that could give you appetite. CBD oil, people use it mainly for nausea. And for some people, it can cause nausea as well. So it's not the treatment, but I certainly see people accessing it for that reason. I think the difficulty in the Australian setting is it's really hard to get a hold of some of these, and they could cost anything between $90 to $1,000, depending where you get it from. And it may be the same bottle or the same substance, active content. And amongst that, even if you pay $1,000, the doctors may just prescribe it to you and say, see you later, and give you no actual help in terms of how do I take it, how do I make sure it's adjust for it because I'm getting side effect from it. And that's where it really, as a doctor, from my perspective, unless you have people who know how to do this, you could be paying the same stuff that you could pay $90 for, and you're spending $600 or upwards of $1,000 for the same stuff. And that really, I think, is terrible, because, as a group, we are really vulnerable enough. We don't need people, gouging our money over this. But unfortunately, this is an unregulated market, and therefore this type of things happens. Technically, any doctor could prescribe it if they apply through the government through a special access screen. But a lot of us don't necessarily have the training for it, and therefore we're not comfortable in titrating the doses, nor am I necessarily be willing to follow up the side effect, because it goes back to the first principle of doctors, is that we believe we do no harm, and really there hasn't proven benefit of marijuana, and so it can be a bit haphazard. Being in Canada, we have much more experience because it's being legalized for much longer. I do see some benefit for some patients regarding appetite and nausea. That's really about the two indications I see where there has been some benefit. In Australia in particular, often because we don't know how to adjust the proportion of CBD and THC, there's implications for driving. If you have CBD in your bloodstream, you are allowed to drive. But right now, if you have marijuana component in the oil, which a lot of us prescribe a mixed mixture, in which case it will have the THC component, you actually physically can't drive. If you got pulled over by the police, it will be illegal. So there's some implication around that as well. Hopefully, I think legislation is changing for that, but so far not yet. So what can you do about all of this? I think the first thing to say is forget about, let us doctors worry about what we need to do for your cancer, but really focus on the importance of your symptoms. And the way I would say that is, again, we come back to the survival curve. Back in 2007, when we first published about gemcitabine as a single treatment, it improved some survival by having the chemotherapy. But the median survival back then was only 22.8 months. Fast forward to 2018, when we published for a different trial and used gemcitabine as a standard, it has a 12-month improvement in survival. And part of that is, for a patient in this trial, they will have to be able to tolerate this a much more tougher regimen. So part of that improvement is because better patient selection, but part of that is because we're getting better at managing people's symptoms. So much so that in trials I have shown, if I was able to manage your symptoms alone and make you feel better, I can improve your survival by 5 months, even if I gave you nothing targeting your pancreatic cancer. And that's what we often forget. And that benefit, dare I say, is as much as what chemotherapy could potentially offer you in the advanced stages. And so focusing on your symptoms, I think, is the most important thing. How do you focus on your symptoms? Is really better recording of your symptoms. In the trials, they do it electronically, and then when your symptom changes, it triggers a notification to your doctor to sort of contact you and talk about things. And that really leads to better physical well-being, symptom control. And so you often go through day and day, everything becomes a blurb. I would encourage you to write it down. And then so you have once a week, you might have a look at it, and then you might see there's some changes that then you can talk to your doctors about at your appointment, because you'll be surprised how much you forget on day to day, because you're so focused on getting to the next day for your symptoms. The other thing people forget about is us doctors is very good at prescribing painkillers, but there are other alternatives to painkillers such as celiac plexus block. And what that really involves is injecting alcohol around the nerves that goes to the pancreas, and that gives us pain. And so basically taking out the nerves that give us pain. And that's how this procedure works. You tend to lie on your tummy for about 30 to 60 minutes. It's done. It's effective almost immediately to within a few days, and the last 3 to 6 months. And for most people, about 70%, it means that you might be taking less morphine tablets, which most of us like because we don't like taking tablets, and morphine causes sedation and constipation. And so we can look into that. And it's something, even as me as a doctor, we forget about this. And so hence why I'm reminding you this, to talk about it with your treating doctor. And so really, I think this is a good summary of what we want. So the reason I share this little clip is it's a fundraiser that one of our patient and Peter Mac put on for the event. But really, I think the song really says so well that we want it all, and we really want it now. And really, there are a lot of things that we can do. I think your doctor would have covered your anti-cancer treatment really well. Hence why my talk's covering on other aspects that they may or may not cover as well because of time limitations. And really for you is focusing on your symptoms, make sure you feel well, and should talk to your doctors about how we can go about that. And these are my acknowledgements. I really thank the patients and families that sort of helped me to get to this point, and all the supports in terms of research, and of course PanCare for their funding of part of my research in terms of assisting us finding new targets and hopefully bring new hope for pancreatic cancer. And that's really what I have to say for today. And I guess I'll open up for questions for everyone to ask.
Thank you, Michael. That was really, really informative, and we will be recording this. So for anyone who would like a copy, please do let us know, because we can send that out. There's a lot of information there to digest, and thank you. There are questions, Dr. Lee, in the chat.
Yeah, so Mike, the survival rates, when I give that terrible statistics, that is based on all comers. In the first initial slides, I have given specific survivals in terms of how that looks like, depending on what stages you are in terms of your cancer. So if I quickly scroll back all the way to the top. There are your survival rates. So if you are the fortunate people in terms of going for surgery upfront, the survival rate at 5 years across the board is about 43%. Whereas if you're in the metastatic setting, your median survival, that means 50% of you get to about 11 months, which is a morbid statistics. But a lot of you do better than that. That's why doctors don't like to put a number on that, because no one is exactly 50%. They usually are better than 50% or they're worse than 50%. And so that's where your oncologist will talk about weeks to months, many months, or longer than the average is probably how we talk about things in terms of survival in pancreatic cancer. Yeah, so the join us, I think there are initiatives like that, and certainly tells you about new drug. And personally, I haven't tried it, so I can't comment on how effective that is, Judy. But I think that's a start, and I think that certainly raising that awareness is helpful, because as your clinician, I'm so tied up, unfortunately, in looking after everyone. I don't necessarily search for every single thing that's outside of my institution, and that's a flaw in our profession, but this is unfortunately the reality, because we simply don't have the when at the end of the day, you are always more invested than we are, in the sense that, because you have more time, where our time is divided looking after many patients, so we couldn't spend all that time. But certainly that would be a way. Robin, yeah, so ATM is a very large gene, and it's one of the genes that we talk about increases risk of pancreatic cancer and increases breast cancer. But the difference is where the defect is in the gene, it has a variable penetrance. What that means is, even if you have the gene, it may not increase your risk for that individual per se, but the next person, say the daughter of yours or your cousin that has it, they actually get a much more higher chance of getting the cancer. And that's the difficulty. Some of these larger genes, and ATM is a classical example of that, is that you will see that pattern of some people getting cancer and some people don't. So it is a very tricky one to have, and tricky to advise. But one thing is, the classical teaching is ATM genes. That's where you may think about radiation for pancreatic cancer, which works better, which a lot of people I generally say radiation is only good for if there's one painful spot. But for you, if you have a localized disease and not spread to other places, radiation may be a consideration. In terms of where you would go for gene tests, I would say you still have to go to your medical oncologist and talk to them about it. It can be as simple as me ordering the tests through a provider. The cheapest one in terms of the 450 is probably the Invitae panel, but that test they're doing up until now, they were sending the results to the US, but mostly they have a lab in Sydney that can turn around the quickest in about 3 weeks. But depending on where you are, there may be contractual agreement that say certain center will only do their tests in certain places. So you may not have a choice necessarily, but certainly have that conversation with your medical oncologist. Tony, thank you for highlighting that. I think where PanCare was helping me in terms of funding was really that combination that I was talking about in terms of PRMT5 and PRMT1. Looking at that combination that tells me how does that combination make my treatment better, and really that then guides me when I'm trying to work out all those signals. It helps me to say, oh, well, if this makes it better, therefore I should look, if I within my data, just on these particular pathway. It helps me narrow down the number of pathway that I need to look at. Otherwise, as I was alluding to using the sheep analogy, is there's so many sheep I can follow, which one do I follow? And having a combination adds another facet for me to filter down and help me to come to the right conclusion. And potentially, right now, what we know, both PRMT1 and PRMT5 have been through what we call phase 1 trials. So that means that the drug is safe to be given to humans, but it also comes at a cost of quite toxic. Can we therefore give smaller doses and make it more effective? Based on preclinical evidence, we can, but we still don't know who is likely to benefit from this treatment. And that's where my work is looking into, and that's where the funding from PanCare allows me to do, because the initial research funding didn't even that we apply for through the government didn't look down this pathway, and that's really because the senior leaders in the group wasn't aware of this knowledge, and because I've done sort of a search through the literature, and that's what I come up with, and that's how I came up with the idea. And PanCare was great to come to the aid and support us and able to further that research, and therefore make the research much more valuable in terms of how quickly we turn that into a target. Yeah, I think Kim, in response to your question that you've done all the things that you can do in terms of chemo and surgery, I think the best thing is really exercise. In colon cancer and breast cancer, if you do intense exercise, and that by definition is 30 minutes a day, 3 times a week, getting your heart rate to about 120, then you really reduce your chance of getting breast and colon cancer coming back by 40%. I would say for a lot of breast cancer women who are having chemo for much smaller benefit than 40%, I would say the same for pancreatic cancer. Now, that would be sort of by inference from what happens in pancreas breast and colon cancer. But at the same time, whatever treatment I throw at you, one of the things it will cause you to do is it will make you lose your condition. So if you like, your condition goes down like this, then certainly you can't have treatment when you get to a point where you feel too tired. What exercise allows me to do is, instead of your tiredness going down like this with treatment, it goes down like this with treatment, or you're starting at a higher baseline. And therefore you have much more distance to fall from compared to someone who doesn't exercise and is bedbound and really frail.
Sorry, Michael, we'll do one more question here.
Yeah, so I think genetic testing, yes, I think generally sake in today's setting, both for cancer and germline, I think you should do them both. I think that's about it, and happy to take on other questions. If Mira's happy to do that in the email, then I can answer each individual one, and she can forward back the answer from me to you directly. So sorry, Mira, I just added a whole bunch of work for you.
No, that's okay.
Happy to help where I can.
Yeah, thank you so much, Dr. Lee. I'm very mindful we've taken up, a fair amount of your time. Thank you for sharing this exciting work that you do for us, for our community. And we hope to see you again and get an update on where you've continued on with your work. So thank you so much.
All right, no worries.
Thank you. You're getting a few claps there.
Thank you.